Well, good morning, everyone. My name is Charlene Gamis, and as a clinical research specialist at InBody USA, I want to welcome all of you to today's webinar in our InBody Present series. Today, Dr. Molinger will talk to us about evaluating longitudinal cardio-pulmonary-metabolic pathophysiology in patients with COVID-19. Dr. Molinger is a clinical exercise physiologist specialized in metabolic cart assessments, metabolic imaging, body composition, and exercise physiology in the perioperative space. Dr. Molinger serves as the program director and senior lead clinical medical exercise physiologist of the Human Physiology and Pharmacology Lab, the Duke Heart Cath Lab, and the Duke Center for Perioperative Organ Protection. He is currently the operational program director of the LEAP COVID study. As no longitudinal data exists describing the cardiometabolic effects of COVID-19 infection, Dr. Molinger will be sharing their findings from the last 7 months. At the end of the talk, attendees will have a chance to ask questions by adding them to the Q&A chat box. So without further ado, Dr. Molinger, thank you.
Welcome, one and all, to this webinar, and thank you, InBody, for inviting me and giving me the possibility to show our results from our LEAP COVID study. A little bit of my background. I showed you this image from me running doing the COVID research. What we're seeing here is just a sec. Yeah. Again, a little bit of my background already said. So mainly right now responsible for the whole metabolic trials here at Duke, recording assessments during COVID-19. And also looking further on in presumably optimizing patients in the COVID survivorship and seeing what needs to be done and what do we need to know before we can optimize those patients when they survived the COVID-19 ICU stay. There was a little bit our background, and I wanted to go a little bit more in depth about. There was a lot of talk about, I think, regarding our latest article. But I want to give a little bit of a different approach to the data we collected and the data we presented in that article itself. I think it's worthwhile that looking at specific breath by breath data from a metabolic card gives you a far amount of kind of an insight in the kind of the whole systemic mitochondrial function of a patient going through a COVID-19 infection. But looking at those data sets, I think we can have a far more broader insight in what the physiology tells us and presumably what we can do or what could be potentially the issues when people survive from this horrible infection. Kind of the keynotes, the rationale behind LEAP COVID. So a little bit about the background why we started off this specific study. The physiology behind resting energy expenditure, but also the VO2 and VOC2, and mainly also in the perspective of systemic mitochondrial function, aka dysfunction. I think when we did our study, there was no data available regarding the potential survivorship after COVID-19 in the ICU. And I think what we're seeing right now, I think some very horrible scenarios. People are still having long-lasting cognitive and physical impairments after ICU stay when they are a survivor of COVID-19. So I think we should be more in line and looking for more in depth in what the issues are when you are in a COVID-19 survivor. So if we want to know how that came about, I think we have to go back and see how this systemic metabolic phenotype is driving during the COVID infection itself on the ICU. And mainly my kind of a approach in this whole way of assessing patients and seeing how their specific systemic metabolic phenotype is changing over time is that I think we need to have a more in-depth look at that phenotype, which we also doing in our elite athletes. So when a patient is being admitted to the ICU, I think it's the patient the same as an elite athlete. I think they are right now preparing for their golden medal and their survivorship, their life. So we have to make sure that the whole team in the CQ MICU is all on the same page and knows which assessments are need to be done to tailor and to personalize the specific interventions needed during their ICU stay. So also looking from a early mobilization perspective, nutritional perspective, maybe even sleep hygiene perspective, I think it's vital to know. Because everyone still wants to survive. And I think it's far more, we need to have a far more in-depth look at the survivor instead of the people who are dying, which of course is terrible. And the death rate is specifically high in this population, being on the ventilator in the ICU. But looking more what the metabolic phenotype is of a survivor gives us far more insight in what we need to do and how we could assess those patients and give a kind of a more predictive rule set in how to intervene. I want to go back to another article we did before, and that was the novel approach to metabolic assessment and structure exercise to promote recovery in ICU survivorship. I proposed a kind of a model where we saw the baseline critical illness and recovery, and I think this was a kind of a way where we look how we should assess a patient in this specific time frames. Only right now, looking from the more COVID perspective, we have some issues in regard to there is no baseline and recovery is still unknown. The thing is, in the center of this whole assessment strategy we are proposing is mitochondrial dysfunction. Mitochondrial dysfunction shows in sepsis and RDS models, but I think right now then COVID came along. So before we were starting off with COVID, we were already preparing a larger trial looking at specific cardio-pulmonary-metabolic dysfunction and mitochondrial dysfunction in our RDS and sepsis population in the SICU and NICU. So when COVID came along, we just adapted this specific population to our already known assessment suite and tried to collect data sets and combine them to the population of RDS and sepsis to the COVID. So is a COVID-19 infection being intubated on the ICU comparable with the classical RDS we already know? And do we see some specific other phenotyping? And I think we do, and I will get back to that later on. So this is one of the proposals we shown that there is a way of, let me get my laser pointer over here. Yeah. So in the center, we have our mitochondrial dysfunction, and you see there's a lot of cascades which can influence the mitochondrial function of the system. And you can look at a specific mitochondrial function like the brain, the kidney, the gut, the muscle, of course. But I think we have to look in which kind of mitochondrial function is more impaired or more sensitive to be impaired during ICU stay and during COVID infection itself. So when we go further on, we set the baseline itself. And that's the thing we know. There was no baseline where we assessed during our COVID infection itself. It's a kind of a thing I think we need to know for sure what kind of comorbidities and underlying illnesses are there. We saw BMI was a very good predictor. Also, the underlying illnesses like metabolic syndrome and diabetes was known in our population. So these are already very prone people who are able to get those infections. I think there is another part, which I will also talk about a little bit later on, but also looking at specific phenotypes like the ACE2 polymorphism, which could also have a potential specific effect in the cytokine storms, which we saw in people who were pretty young and pretty well nourished and pretty fit. So further on, then we already know the baseline. I will show you some data sets where we show our baseline from our study itself. The recovery, and I think that's still a unknown. I think going back to the data set we already know is that there is a lot of, there's not COVID data, but there is a lot of people who are being functional impaired post-ICU based on RDS and sepsis numbers right now. I think, but that's kind of anecdotal, what we're seeing right now is that there's a lot of people who are still, and even people who are not being admitted to the ICU at all, still have long-term functional impairment due to their COVID infection. So in the base, it is a respiratory disease, a respiratory distress disease. But I think when you're looking more in depth, you see a far larger amount of organ systems being impaired and having issues. And I think that's what we're seeing right now. There's there's no data coming out looking at specific way of how do you define low physical functioning and impaired of performance. I think we need to have a better look and a better way of assessing patients in the post-COVID time to make sure we're giving them that specific tailored intervention, like nutrition, like training, and like sleep hygiene, and maybe even even medication. But we know we can only do that if we know how the specific phenotype is driving the infection itself. So going back and showing the whole cascade of mitochondrial function, we proposed a specific hypothesis, and that was that the persistent hypermetabolic and hypercaloric phenotype in COVID-19 leading to post-ICU weakness and loss of quality of life. You can see over here, there's a whole cascade what happens during a SARS-CoV-2 infection, which you know is of course the whole cytokine storm, which you can argue that could be also a specific metabolic storm, which we show in our data, which I'll show you just in a couple of minutes. The thing is, how can we assess this specific mitochondrial dysfunction, and how do we drive this mitochondrial dysfunction in our assessments with usage of modality like imaging, CT or ultrasound, or using the metabolic cards, or using specific hemodynamics or body composition like the multi-frequency bioimpedance assessments. So again, in the critical illness, we posted already in our article that the way of using them is assessing them in the way that you should assess also kind of an athlete. So we have here CPAT. CPAT is kind of a hard thing still to do in the ICU. We're still trying to figure it out how we can put a specific kind of created exercise protocol to kind of metabolic stress patients on event and not on event, to see if you can have a specific assessment of their VO2 kinetics and dynamics. But of course, we can do in rest in that kilometry. We can do muscle ultrasound and looking at specific body composition, muscle quality, muscle thickness, and muscle area, and CSA kind of changes. Body composition overall, looking at segmental intracellular water, which we derive from the InBody S10, and of course risk scores like also and severity scores like SOFA. The assessment we did was, it's kind of the whole range of assessments what we did in every single third day of the ICU stay in our COVID patients. And our latest article being published in Critical Care was mainly driving the data sets from our Q-Energy Cosmet in that kilometry metabolic card device. I will show you some combination of data sets looking at those data from the in-net kilometry, but also looking at data from the hemodynamics done at the same time, and also looking at data from the muscle sound, where we can derive specific histology, morphology, and architecture of the leg muscles, but also intercostal muscles and also the temporalis muscles. And of course, what I already said, the segmental way of assessing intracellular water, total body water, and also looking at specific ways how visceral fat distribution is changing over time. And last but not least, the transcutaneous O2 and CO2 assessments, which is kind of a derivative of mitochondrial function, dysfunction of the dermis of the skin. We are still looking into these data sets and see how they correlate with the other stuff we're seeing in the innate kilometry hemodynamics, but also looking at specific changes overall in the muscle, which could also be a proxy of the changing of the systemic metabolic phenotype during ICU stay. Okay, let's start off with the article itself. I think it's already known, the persistent hypermetabolic and longitudinal energy expenditure in critically ill patients with COVID-19, our LEAP COVID study. Kind of a more approach where we're seeing is how did the patients look like? And I think it's already been shown that we had a very high number of African Americans. Also known the BMI was typically higher, so our obese and morbid obese patients were at a higher group. Our ventilation days mortality and 21-day mortality was, I think, were normal numbers. We're still looking at, but I cannot show them not of yet. We're preparing a new article where we saw that specific cohorts within our overall cohort of COVID-19 infection people, of subjects, shown specific signs of neuropathy and lower motor neuron disease. We're still looking into these specific signals or specific symptoms of a kind of a persistent kind of a ICU acquired weakness profile, which showed kind of linearity with our hypermetabolic phase, what we assessed during our metabolic cost assessments. There's a lot of discussions. I think there was a lot of discussion be done during our, there was a lot of Instagram pictures. I think everybody knows. This guy from California is also, it's a cool guy. He's also a nurse. He shown his pre and post images of his infections and intubated, which you of course can see over here being tracked, and also his specific change in his metabolic phenotype from a pre and post environment. I think he had an average, his lean muscle mass, I think was around 30 pounds or so, 30, 40 pounds what he wasted. The thing is, the question was that the reason why people tended to think that the reason why he survived was based on his very hypertrophic, very high lean body mass, which he showed before. I still am in doubt. I think we are, that's the stuff we're looking into right now in our subject itself, that maybe his phenotype shown over here was the reason why he got so sick, based on a specific polymorphism in the ACE2, which shows a specific responsiveness to resistance training. So you get a very easy way of gaining muscle mass, being low grade hypertensive, which can have a huge effect in your cytokine storm. But that was shown in our potentially our younger patients here in the Duke and the CQMQ. And there's still a lot of debate that I know muscles matter, but does more mass really matter? We don't know. I think we still have to find out if that specific phenotype is more prone for a very high cytokine storm. Same over here, showing the potential polymorphism in the ACE2. Still have to look into it. I think it's a specific phenotype, but we've shown people being very young and still getting specifically very ill. Not to be discussing this talk right now, but we're still preparing some articles in going more in depth in the ACE2 polymorphism. Okay, going back to the data set itself, what we saw was, and that was kind of neat, that there was a specific normal or kind of a normal metabolic rate, and in week 2, from the 7th day over here, we saw a specific increase in our hypermetabolic state. And when we compared the obese to the non-obese, we saw that the non-obese show a tipping point, and then they decrease the metabolic rate, where the obese people, still not significant, but shown a kind of a prolonged kind of hypermetabolic state. Still, we're looking in those specific phenotypes and what the reason was there was so high in their metabolic rate, and potentially looking at the substance utilization, hemodynamics, that specific point on, which we measured also with 20 and on. But there's an article still coming up. Also good to see that the variance and the variation of those specific outcomes are very high from week 2, week 3, and week 4 on. So that's the reason why we saw that in this population itself, there is a subpopulation which shows specific signs of ICQ-acquired weakness. We still have to find out how that's correlate, and is that specific group significantly different than the group that didn't show that those specific signs. When we compared it with our sepsis, of course, our sepsis and RDS patient didn't show a specific first week and our second, third week kind of a change in the metabolic rate. We saw also, and that's kind of specific, that the sedation and also SOFAR scores were not correlated at all with the hypermetabolic state. So even multi-organ failure was not at all correlated. We saw a lot of changes over time with specifically, again, In week 2, a lot of variance, but the surface course itself did not correlate, or did not correlate well with the hypermetabolic state. So if you go back and look at what we're measuring with our metabolic card is VO2 and VCO2. And one of the specific what we're interested in is our VO2 measurement. So if you go back to the physiology itself, we have to get back to the so-called Fick equation. And the Fick equation is telling you how the VO2 is being derived from. So here you see on the left, you see the cardiac output. And you have to multiply cardiac output with the arteriovenous oxygen difference, which the evasive, when you have a very large evasive, you have a large amount of oxygen extraction and a large amount of oxygen consumption, which in turn also gives you very lower saturation in your mixed venous blood. So there is a peripheral and there is a central specific way of gaining or uprising your VO2. So what we did was, during our metabolic carb measurements, we were also measuring hemodynamics. So we were able to drive cardiac output at the same time that we drove our metabolic carbs with the VO2. So again, looking forward here, you can see one of our patients being prone. The thing is, if you're looking here at that specific data set, you see that they are hypermetabolic based on the RE over here. You see the high RE over here is specifically very high, with 136% of predicted of the Hesbandek equation. But if we drive further on and looking at the VO2, we see a 494 mils per minute. At the same time, we also drove our cardiac output measurements, and then we saw these kind of numbers. So if you combine those sets, and we're going back to the Fick equation, where we saw that if you have a VO2, and when you have a high cardiac output, the only way of having a high cardiac output is that you're driving a very low evasive. So the inability to extract oxygen from the peripheral tissue. So there is not a lot of oxygen consumption. You have a lot of delivery, but not enough utilization of oxygen inside the peripheral tissue. So if you then gain and get those together right now, from a perspective from the heart, you can say they were running a marathon. But from a perspective from the utilization of oxygen extraction in the peripheral tissue, they were just sleeping. So this guy, this patient over here, was doing a long-term hiking of still around 2 meds, 7 days a week, being sedated, being prone to supine, mainly based on a very high cardiac stress and a low oxygen extraction, which kind of a compensating of the cardiac strain is just a compensating mechanism of a low extraction of oxygen in just increasing flow. So in this terms, what we're seeing is that the heart is just the slave of the cell. And what we also drive from those specific assessments was, we call that the RQ over RER. So the RQ is a kind of a ratio between the O2 and CO2, which drives or gives you some insight in the subutilization, what we're seeing over here in that specific time frame. So are there more utilization of lipids, or more carbohydrates, or protein? And of course, we know the protein is always there. There's also protein breakdown. And so there's a kind of a mixing of those substrates during that specific time point. So what we did was, we also tried to figure it out, did that RQ change over time? And we saw that there was a specific here, you can see a upslope and a downslope and upslope again in our RQ, which goes up again here around 0.8. 0.8 is around 0.75, 0.8 is kind of normal. You go downwards here at the beginning of the first week, which shows the potential subtilization of lipids over here, changing over time, going a little bit higher, going more to carbohydrates, go a little bit to lipids again, and to carbohydrates again, but we show also here a lot of variance. In a previous study done with my other colleagues, they've shown that if you're looking at survivorship in sepsis, that the change in RQ over time is a kind of a potential predictor of survivorship. So if you're still leaning on your lipid oxidation throughout your stay, you're a potential non-survivor. If you are changing over time, going from lipids back again to carbohydrates, then you're a survivorship. One of the things we are looking into, that the first week you're still insulin resistant. So there's no way of utilizing glycogen or carbohydrates in your system at all. So the system tends to lean to more lipids. But the hybrid state of the system, so how flexible are you? How metabolic flexible are you going from lipids to carbohydrates, lipids again? That makes you potentially, I think, a survivor. Again, it goes back to the more the mitochondrial function itself. So not only at the delivery of oxygen into the cell mitochondria, but also how mitochondria are using this specific oxygen and utilization of lipids and carbohydrates and protein. So again, this is what we've shown. If we have an altered substrate utilization change, which was already being seen by different other colleagues like Jeroen Molinger, in I think one of his biggest, his best articles yet, showing that the metabolic phenotype of skeletal muscle and nearly critical illness, that he's shown that skeletal muscle wasting and critical illness is associated with an impaired lipid oxidation and reduced ATP bioavailability. So driven by systemic and intramuscular inflammation, this is what we saw, and this is what we're still seeing in our COVID patients. So the decreased mitochondrial biogenesis and dysregulated lipid oxidation can contribute to a compromised skeletal muscle bioenergenic status. So if you go on, and we saw already that there are specific changes in substrate utilization over time, maybe the specifics change over time, and still when we are giving patients nutrition, one of the ways of giving them nutrition is also giving them lipids, also from the more medication like propofol. But I think looking at the more myostinous way, where you see an increased fat infiltration inside the muscle, given a whole cascade of changes from a more kind of a metabolic dysfunction, but also potential a functional outcome dysfunction. So if we were able also to utilize or measure or assess the change of muscle infiltration of fat during their stay, we can also have a more in-depth insight how this muscle is changing over time. So if we're looking at the altered muscle composition and function, which we know already that specific muscle changes, specific mitochondrial function of the muscle is specifically correlated to a lower VO2 peak, lower VO2 max, seen in different other studies, even combining muscle fat infiltration from the level of L3 to a CPET outcome, but also looking at single fiber analysis, looking in the respiratory chamber in how the specific VO2 of a fiber correlated well with VO2 in the unconditioned patients or subjects that we're seeing right now, potentially before surgery, but also in our ICU. So body composition, we know already, is being shown many years right now. If we are looking at the modality of CT, one of my colleagues in Amsterdam, Willem Looijaard, showed that the muscle quality, looking here at the CT scan at the level L3, where red is muscle and green is intramuscular adipose tissue, IMAD, that the amount of IMAD was a very good predictor for 6 months mortality in mechanically ventilated critically ill patients. So CT is not a very easy way of assessing patients because it's still very invasive, and from an ICU perspective, it's very hard to get people into a CT scan. But if we can get this modality also being used from an ultrasound scan, for instance, I think we can have a far more point of care, easy assessment, and more sequential way of seeing changes over time in a muscle. We have seen that there is a muscle sound, for instance, is a platform which uses muscle images, diagram images, which have a specific way of ego intensity changes over time in a texture way, but also looking at the deep spots, which are showing more water, comparing them with the more gray showing less water. Validation against muscle biopsies for glycogen has been done, but also looking at specific texture and equitency changes, validated against MRI, thermal-rated images from a 3-day voxel pixel against the pixel equitency changes in an ultrasound picture. So the platform itself is an algorithm which drives those validations and the ability to assess glycogen levels inside a specific muscle of interest, but also driving intramuscular adipose tissue content in specific planes. This is a short axis plane of a rectus femoris muscle over time. And also you can, of course, then assess different muscle groups. This is normal what you see. We see 255 grayscales inside the muscle. We already know we are seeing with our eyes around 30 or so. So there's a lot of data over here in this muscle which we just cannot see. Driving a heat map scale over the muscle with a learning algorithm which shows fascia, connective tissue, aponeurosis, gives you far better insight in how this muscle is changing over time. So here you can put the algorithm, kind of a heat map, and this heat map will drive, you can see the specific darker areas which show more water against the more neon pinkish areas which has less water. And the reds, sorry, the whites over here is connective tissue. So if you want to evaluate mitochondrial or metabolic function of this muscle, so to speak, I don't want to have this kind of connective tissue being implemented in my score, because this is not oxidative material. This is not oxidative tissue. So the overall algorithm drives only the tissue, which we know is muscle itself. You can see more in depth kind of a way of how we see low water content in different regions. This is kind of a reference picture of a normal rectus femoris muscle in a short axis assessment. I will show you some other pictures, give you some little bit of insight how it shows in different kind of states from illness and disease. On the left, you see an healthy control. In the middle, you see a frail sarcopenic patient. With on the top, you see the dermis and the subcutaneous fat layer, and also the connective tissue inside the fat cells itself. Here you can see they're almost pancake kind of form of the rectus femoris with specifically a fusion surrounding the muscle. What we're seeing over here, when you have an overflooded patient, so a fluid positive patient, it doesn't tend to go inside the muscle, but only outside the muscle. You can see specifically over here also in a sepsis patient, a fusion between the fascia of the intermedius muscle and the rectus femoris. Over here, again, what I said, we see changes over time. You can see very well, if you don't have any knowledge about histology about a muscle, where you can see very well the distinct differences between texture and ego intensity changes. If you put the algorithm over it, you can see a far better insight. And what is striking to see that the sepsis day 5, looking at the cross-section area of this muscle, that you only see the water content of the muscle is only this part of the muscle itself. So you would overestimate the muscle as a metabolic profile perspective, only looking at the CSA and not looking at the histology and morphology of this muscle, which we can drive on from these images. To give you some little bit of insight, what we saw in our COVID patients, very specific, we saw differences in, I think there were similarities with our RDS and sepsis. One of is that the physical CSA is changing, but mainly it changes like everyone becomes a pancake in the ICU, just due to gravity, potentially neuroblockade and propofol, which has specifically changes in the potassium and sodium channels, will give you a lower membrane potential. And it's also one of the things I'm still trying to get into the kind of a default way of thinking in the ICU, is making sure putting the legs of a patient in a neutral position with a little bit of an exrotation, because that alone, with a very high exrotation or enrotation, changes morphology oxygen over time very rapidly. So here we see a rectus femoris muscle, an intermedius muscle in a week 1 and a week 2. What we saw is that mainly also the intermedius muscle is changing over time very rapidly. It's still one of the things we're looking into in one of our upcoming articles. I will get more in depth about changes in the intermedius muscle and how that comes about in regard to histology, morphology, maybe also in regard to propofol during the ICU stay, maybe also during neuroblockade. kind of anecdotal sense, because we're still going into the in-depth analysis of our InBody, even the raw InBody set, building models of it. But this is a kind of a change what we see from a patient who survived more than 55 days on the vent, which shows this is what he got from a visceral fat area from the beginning. This is how he ended up with. And you can see very well his weight and also his skeletal mass. So he had a significant loss of his overall fat mass in during his stay here in Duke. Also, anecdotal, the patients that tend to die. And again, what we're seeing right now is the ability to utilize fats. I think it's one of the metabolic flexibility profiles you have to alter this illness and to survive and to strive. This is a patient that unfortunately did not survive, and he started off other way around. So he was, upon admission, very low at a BMI of 17, ended up also with a BMI of 17, but he was lean fat. So he tended to only have muscle fat infiltration high and also visceral fat infiltration high. So what will be our next steps right now to see? I think looking from this perspective, it's mitochondrial function as a kind of our tipping point where we're looking into getting all those other stuff together and making a kind of a whole body, a whole model where we're looking at plasma biogenic profiling, where we're looking at specific mitochondrial function of platelets and PBMCs. We're looking at specific driving of all data sets together and presumably making new algorithms will give us far more insight in potential survivorship and what is the specific metabolic phenotype of a survivor in regard to people who die. Thank you.
Well, thank you so much for sharing that, Dr. Molinger. It's great research. We do at this time have some questions from the audience that we'd like to ask you. The first one being, as most COVID-19 patients came in already under extreme metabolic distress, specifically in the ICU, how do you know how severe the disease is without baseline?
Yeah, that's a good question. I think what we are seeing right now is that that's kind of intriguing in the data set that we saw even the first week after intubation, they were not that hypermetabolic. That was only the second week. So their specific stress level or inflammatory levels upon admission did not show the specific metabolic hypermetabolic state which we assessed during their stay. And that's, I think, very differently what we already know from our RDS sepsis patients in a more classical way. But definitely one of the stuff we still need to see. And the baseline, yes, that's one of the issues which we don't have. One of our studies we're looking into right now is also driving and assessing patients on the floor, so that we have a kind of more trajectory from our sequential measurements going from the ED to the floor to potential SICU-MICU, to have a more insight in that changes over time from a metabolic perspective. And again, sure, we only assess them in the ICU, so that's there could potentially some confounding over there. Yeah.
Great, thank you. Now, continuing talking about COVID-19 patients, what would you consider to be the 3 biggest challenges in treating them?
The biggest challenges, I think, still is, from an ICU perspective, is still weaning from the ventilator and even getting them on the ventilator, because we're seeing if you're on the vent, your risk of getting off the ventilator are potentially lowered, so your mortality risk is significantly higher. I think one of our foremost struggles we have is how to early mobilize those patients, because they don't look the same and they don't respond the same as we know in our RDS and sepsis patients before. So I think this kind of research in regard to cardio-pulmonary-metabolic function through their infection, I think is of vital importance to have more kind of a personalized way of treating those patients during the ICU stay, but also after. And I think we know that this kind of research is not very sexy, and that even intervention studies like randomized are far more sexy for us to see. But right now we're trying to combine even to see if we have a specific metabolic profile which shows a far more better response to those interventions. I think that can be also beneficial for people who are going to have a specific response to remdesivir or immune or antibody therapy right now, which we just don't know.
Mm-hmm. And I think it's great that you're bringing to light the type of research that you are doing, because more people need to hear about this. Now, do you see any key differences in specific populations, such as those with comorbidities, chronic diseases, or even adult versus pediatric patients?
I have not seen yet any pediatric patients yet. We are right now starting and getting into specific assessments at the same as we're doing right now in pediatric ICU. I think overall, BMI, morbid obese, metabolic syndrome, and diabetes are one of the foremost underlying diseases who can potentially give you a far higher risk of getting so sick. Nevertheless, again, we saw specifically patients being very low in age, being specifically very well fit, who still got this disease. So, and again, I mentioned before the ACE2 polymorphism. So there are specific ways, I think, which shown that you still can have the disease. There is not a single bullet or 2 or 3 single bullets where you know for sure you get the disease. I think everyone still can have it, and unfortunately can have a serious critical illness of it.
Mm-hmm. I can agree there. Now, looks like we have another question here from the audience, and you may have touched on the specifics of this earlier in your presentation, but which body segment do you look into for muscle imaging?
Oh, good. Yeah. We have a specific. We look at, of course, the muscle of the leg. We use standard of care CT, and that's mainly at the level of thoracic 8th, 7th, based on CT scans done for predominantly standard of care for the lung. We did intercostal muscle, we did diaphragm, we did temporalis muscle of the head, and we did tongue muscle. And we're still driving those data sets and see how, for instance, temporal wasting in regard to wasting of the leg give us far more insight in the overall systemic metabolic profile. Because what we're trying to seek, and what I'm trying to search, are there specific muscles that we can assess very easily, or can give us a kind of a proxy for your overall metabolic systemic health. Of course, muscles of the leg are there, but I think they are sometimes harder to assess due to catheters and all that stuff. So if you have the potential maybe to assessing patients from the tongue or from the head, we could have far more insight in those changes, and very point of care and much easier.
Mm-hmm. Now, muscle, as we know, relates to cellular health integrity. And we noticed in the surviving patient, the ICW, or intracellular water, sustained while the ECW decreased, which would indicate a decrease in edema. Did you also happen to track phase angle as it does relate to cell health?
Yeah, and we're still right now in the middle of our analysis. One of the things we're trying to figure out how phase angle and mitochondrial function derived from our blood analysis somehow correlates. So we know that phase angle has a kind of a weird black box around membrane health and cell health, but maybe it gives us in this specific population a more easy way of assessing changes over time from a more kind of a mitochondrial perspective. And I think it's kind of a neat kind of way because it's so easy to do. And maybe even not only looking at the whole body phase angle, but also looking at maybe phase angles for specific segmental specifics. Yeah.
And we definitely look forward to seeing that data as you continue to collect that. Now, you spoke about significant muscle wasting and loss of function throughout the course of illness and even during recovery. Based on the data that you have so far, what would you say are the top ways we can care for those recovering?
From a nutritional way, what we saw right now, I think one of the key elements is we have to assess patients by metabolic cards during the ICU to making sure we have our nutritional needs in place, because we saw using our let's say classical formulas in predicting the caloric needs, we were all over the place. We're we were seeing that changes over time were very significantly different. We underfeed, overfeed. So you have to be sure that you are giving patients literally what they need, and you only can give them what they need if you assess it. So that's one part. And based on those changes, it's also looking in specific early mobilization, maybe even from an electrostimulation point of view, because that's still stuff that needs to, I think it needs to have more familiarity in the ICU itself, looking from a ventilator perspective, so at stimulation of the abdominal muscle or the intercostal muscle. But also look at a specific low-grade stimulation of the muscle of the leg, to making sure not that you keep your muscle function or your not muscle function, but your muscle conductivity high, but that you're making sure that your architecture and your connective tissue stays in place, because that's one of the things that muscle wasting does to you, that gravity always give and change muscles instantly.
Mm-hmm. And as you say, muscles matter, right?
Exactly.
Do you think there's a correlation with hypertension, high blood pressure, and COVID patients?
Yeah, for sure. That's one of the, I think looking at the metabolic syndrome, of course, you see hypertensive patients already, but also low-grade hypertensive patients shown, we're seeing right now in our underlying illnesses. And there's also potentially one of the specific symptoms which you see from our ACE2 polymorphism, the low-grade hypertensive patient. The thing is, we just don't know why and what the in-depth phenotype of the patient is, why they get so sick.
Mm. And based on your data so far, what have you noticed in terms of organ failure and how this may read on the InBody result sheet?
I think we did not see any specific change. What was from a multi-organ or organ failure perspective, mm-hmm. It was for us kind of weird to see that. We saw that there was no correlation at all with hypermetabolic state. We saw, and that's what we know before, that muscle wasting itself was highly correlated with multi-organ failure. And now we saw different. We saw that the hypermetabolic state was not at all correlated, and also change in the muscle not at all correlated with multi-organ failure in those patients. That's the reason why I also started off with, I think it's a disease or a virus that starts in the respiratory tract and gives rise to a cytokine storm from that specific organ. But then on, in that week, setting up in the third and the second week, changes will give from other systems, and that in the end will give all those horrible side effects, long-term side effects from a connective point of view perspective, and also from a physical perspective, long-term.
Now, you also spoke of metabolic flexibility as being a possible key factor to survivors of COVID-19, and you may have mentioned this, but are there promising findings as to how this can be manipulated at all while in the ICU? Yeah. We know intermittent fasting can do this with ambulatory patients.
Good question. I think even I don't have a straight answer yet, because this is also one of the things we were doing in our pre-COVID time, looking at the more preoperative patient, where we also saw specific change in their substrate utilization, so the impairment of using lipids in their resting kind of environment. Also, if we stress them, they don't have the ability to utilize fats very well. So it would come to kind of call it mitochondrial reprogramming, to give back or to somehow reset the system, and to see how this mitochondrial function and utilization can be somehow kind of enhanced somehow. I don't have the answer right now. I think the cool potential there is research done from kind of a nutritional supplemental point of view. Are there specific nutrients we can take who have specific mitochondrial influences on the system itself? Could this combine with electrostimulation, for instance? I don't have a clear answer right now. No.
Well, just wanted to get your thoughts on that. So thank you for sharing. And as part of the InBody clinical team, we have been recently looking into frequency-dependent impedance characteristics in ICU patients. I'm curious whether you've looked into impedance, and if so, could you share what you've seen in your patients using the InBody S10?
No, I truly do not know, because we're still right now, my team from bioengineering right now is looking at all those data sets, and because we want to have a complete model of combining all those data sets. We're not looking at specific one outcome. We are doing definitely our raw data analysis of those data sets itself, and I can tell you we have a fair amount of S10 embodied data, which we share, I think, in the very near future, because there will be a big study, a big article coming up. Yep.
Great. Definitely look forward to seeing that. Now, what unexpected challenges or promising results have you seen with your patients who have been discharged?
I think what we are seeing right now is the continuum of being fatigued and cognitive impaired in regard to concentration, lack of concentration, overall impairment of your exercise capacity. And the weird thing is, of course, you expect that for people being on the vent or in the ICU, kind of a post-intensive care syndrome kind of perspective. But also we're seeing that patients who were only on supplemental oxygen on the floor. So, and I think, to be honest, I think that group is far more bigger than the group I saw. We saw just the tip of the iceberg, because the people were being submitted on the floor. I think overall in the world, also in Europe, are far more bigger than people admitted in the ICU. So that's the reason why we're also trying to start off the research looking at those people being admitted on the floor and seeing how those specific phenotype is changing over time, and also give a kind of a more insight in their survivorship, because we need to have some more kind of hands-on assessments where we can tailor our interventions in the during the COVID survivorship time. Yeah.
Now, Dr. Molinger, before we conclude, I would like to go back to a statement you shared with us where you said, we need to learn from athletes to treat our patients better. What made you want to switch from working with healthy athletes to now treating patients in critical care? And how do you manage the difference in goals between the two in order to really achieve those best possible outcomes?
Cool question. And one of the things I'm always curious about is physiology in a kind of integrative way. So when we are assessing athletes, we also want to have a kind of more in-depth knowledge about their way of recovery and their way of performance. And it always it strikes me that we have all the money and time in the world for an elite athlete, where we are in a team of 12 and all, from a more nutritional, sleep hygiene, nutritional performance recovery point of view, and that all the resources in the world are not there combined in our clinical world. So what I did was, and it's kind of a unique stage I have, that potentially assessment we did in our elite athletes, and I translate that to our clinical population, and specific clinical assessment we did in our clinical world, I go back and use that in our elite athletes and combine those sets and learning from physiology, how physiology changes in regard to metabolic flexibility, in regard to performance of like a VO2. I think it learns you a lot about how that system can change and being optimized, not from an elite perspective, but that every system can be optimized if you know how the system is being built on. And again, I find that in the clinical space, where everyone does such a great job, and I think everyone goes into the work for the very best. But I think one of the biggest issues we have is we tend to be multidisciplinary, but the stuff is that we just don't talk. I think we have to be interdisciplinary to talk to each other, that the nutritionist, dietitian, nurse practitioner, PA, and attending physician on the ICU can combine their efforts and making sure that nutritional-wise and exercise-wise and training-wise are all combined and tailored to the specific need of a patient, which we also do right now in our elite athletes.
Now, what would an ideal rehab recovery clinic look like for COVID-19 patients based on the research thus far? I would imagine an influx of these patients in the very near future.
Same. No, definitely. I think we are still also here in Duke looking into a specific clinic for post-intensive care syndrome patients, of course, with a specific focus on our COVIDs. I think there will be a start off in I think how we would approach a patient in a unique way, assessing his physiology from a psychological cognitive perspective, but also from a nutritional, sleep hygiene, overall perspective. Yeah. I think that's definitely the step we need to do, need to go on.
Great, thank you for sharing that. Now, it looks like we still have a lot of questions coming in for you, but unfortunately we are getting close to the end of our time together. Dr. Molinger, do you have any closing remarks you'd like to share with us?
Yeah, make sure, again, and I think that's one of the vital things, if you're working in the ICU and doing research, or you're a healthcare professional in the ICU, make sure you talk to each other in regards to what you're doing. The RT, the physical therapist, the dietitian, the PA, tend to do their stuff, I think, very well with utmost of passion, but I think we need to talk to each other more, it's all teamwork. It's all teamwork. You're going to do it yourself. And those assessments help us giving far more insight, and we have to do it together. And I think that's kind of a neat thing right now, yeah.
Thank you so much again, Dr. Molinger, for taking the time to talk with us today. To contact him, please use the email shown on the slide, jeroen.molinger@duke.edu. We hope this was both informative and inspiring, and that you will consider joining us in future webinars. Please contact us at clinical@inbody.com if you want to have a conversation with us about applications, or if you may be interested in sharing your research with us and other researchers from this forum. Also, please contact us if you need a certificate of attendance to apply for CPEU credits or CPE credits if that applies to you. Again, Dr. Molinger and all of you in attendance, thank you for your research and working on the front lines during this pandemic so that we might all benefit from your findings.